bring in a very important engagement regard to cancer care. After spending some time in Stormont, we went down to Dublin and here in 4 courts where we pretty much again engaged with the judges and the courts in Ireland. And in between, this is interesting, I bring it up because it's really very valuable. In between, it was just happened to be the graduation week here at AUB. And as many of you know, I served on the board of trustees of AUB. And so between Belfast and Dublin, I stopped in Beirut. And that matter, we had a piece in the Nahar newspaper where we said the story of 2 cities, Belfast to Beirut, where we again engaged and said the important thing about that genetic material of the Lebanese people is owned and retained by the Lebanese people. To that matter, we're very proud that our effort with AUB is carrying on. We have more than 1,000 samples of different cancers. Already it's published in JCO, Global Oncology, and if anything, we made it a point from the beginning, the tissue remains at AUB. It never goes anywhere else. Despite that we work on it and we really do research on it, but it's all retains at AUB. And that matter, where are we going from there? Of course, the future is we can do as much as we want in regard to checkpoint inhibitors, but I think the future is going to be in CAR-T. And this is where really we need more of that tissue that's really very particular because as we all know, CAR-T is not more about seeing the cancer, but more about smelling the cancer. We're going to really get rid of it altogether. And this is what we're doing, currently retaining on building more mouse models for that purpose. Hopefully it will bring up for that purpose. What we're very proud of, actually, all that efforts actually led me to the White House, where we actually had an engagement with the government, tried to learn into it. And at the same time, also it led us to, and I kind of was very proud of that, we actually had a ceremonial event and we met on the board of the USS Missouri. If anybody knows, USS Missouri sits in Pearl Harbor in Hawaii. And USS Missouri actually is where Japan surrendered for World War II. But interestingly, at the moment, the most number of tourists that come to USS Missouri is from Japan. And at the same time, what the US Navy does is to try to kind of, celebrate this as an act of, what people bring together. So we had this meeting, and I quote here, you can see in the front, a very well-known name, Larry Norton, a great oncologist also from Sloan Kettering, and we really brought in the team from around the world to look into that medical diplomacy engagement that we are very proud of. To that matter, and this is an important message for all the young fellows to wrap it up and young students. To that matter, the United Nations got very interested in our work. And at the moment, we have this invitation from the National Defeat Cancer Partnership, part of the UN. We are going to have a meeting in Geneva, because Geneva is where everybody can go. And at the same time, there will be granting support money for young students, young residents, young fellows, junior faculty, that really, if they can bring in ethics science, remember we're talking only science, nothing more, but science and medicine, is to make sure that what can really teach us better about cancer development, especially where there is a conflicting part in the world, and will be supported as such. So this is coming, stay tuned, hopefully we'll see you there. And I wrap up by really bringing this model, because this is exactly what we're talking about here. Interestingly, part of your work that you do and what we all do as physicians or future physicians is patient care. You see it in blue, like this is circle. Interestingly, if you continue to just see patients, it's going to go just on a very kind of continued flat line, or at least a certain kind of elevated line as you go. But when you bring in research, when you bring education and you bring data, and this is what we're really reflecting on, you'll have now an exponential curve, and this is what the Solow model. Solow, the name is well known, he got Nobel Prize in economics, but the idea is you cannot really make a differentiation except by the innovation of the population, which is right and through, it is really all of you. Why is that important? Because ultimately, it's important to think globally. We really think broadly. We don't really focus or fixate on where we are. As you see, globalization will depend a lot on the local taste, what we like, what we do, what we eat, what we study, what we're interested in, the technology available, any component that are to endow that factors, especially in regard to the specifics or interest. You get a certain performance, but you cannot really enhance that performance until you really care for your own people, and this is where you get what's called the economic performance. This is where you are, you're part of all of that big picture, we are all part of it. As you can see, we carried on all that work. We don't see it in that narrow scope of the care, but we see it in a much broader perspective, which I'm happy to discuss with you at any time. Thank you very much for listening.
Thank you, Dr. Abu Alfa, for this insightful presentation. We have room for 2 questions.
If you allow me, Ghassan, first of all, thank you very much. Just for people who doesn't know Ghassan Abu Alfa, Ghassan is a big supportive of our students across all universities in Lebanon, medical student, resident, and fellows. Like every year, we were happy to have one of our fellow goes to Ghassan for advanced fellowship program. And those usually became stars in Lebanon and in the US even. So Ghassan, how you balance your life between your clinical work, research, administration, School of Law, and many, many other initiatives. And it's amazing. Just give us a hint how you do that.
Oh, thank you very much. Thank you, Hazem, for your nice words. So I'll give you the secret. I work on a different clock. Well, let me tell you this, and this is really very easy. By the way, where I stand, each one of you, without any exception, you can do even better than this. Because remember, I started same like every one of us. It's not like any different per se. But what's important, I learned one thing, was when you want to do something, just do it. Don't wait. And this is really what's important, just engage. And organization, organize your timing, organize your kind of abilities. You'll be amazed how much time you have for that purpose. So it's definitely in all of you, just focus on your work and look at the big picture, look for humanity as a whole, which I really give credit for Dr. Badran. When he called me and invitation for here, he said, we like very much to really celebrate what you're doing for humanity, and this is exactly what we're here for. Thank you.
I have one question, actually. Sure. How do you envision the impact of the biologic molecules in underfunded cancers and in other cancers other than GI ones?
Sure.
How do you, if you can elaborate, please?
You know, by all means. So remember one thing. The way we think about it is chemotherapy is nothing more than toxins. It just kills cells, as simple as that. Target therapy is like, you're like really going after targets, like sniping in a way. And interestingly, we're knowing more and more what we thought originally could be random by error. Our faith, especially in Lebanon here, Man Allah, Man Rabbna, this is what we hear. But at the end of it is like some error happens somewhere. Those cells are reproducing, like somebody in the factory. And by 4 afternoon is kind of a little bit tiring. A certain nail was supposed to be in that hole, by error goes to that hole. A lot of errors happen in us all day, but interestingly, some of them can go in the wrong hole enough that can really be productive for more cancer. So as such, understanding the genetics of the cancer is very important. Believe it or not, we have data, we didn't publish it yet, but work that we're doing, especially with our colleagues at the AUB, we now actually have an understanding about the genetic alterations that happen in certain cancers in Lebanon, even in different parts of Lebanon. Why is that? Because remember, there's a lot of intermarriages in Lebanon, different environmental exposures in Lebanon. So really it's important because this way we can get the right therapy for the right people. And with this said, then we kind of enhance to really now not only just kind of go after the target, but I think immunotherapy was a major driver in regard to the care. Now, all of this, by the way, is a formula that doesn't apply only to GI malignancies. We're going to hear next from Dr. Shweira about all of it in GU and other malignancies as well. And by all means, expand the horizon all the time. As you remember, for example, the IDH1 is a story that started in GBM. It doesn't have anything to do with intraepithelial carcinoma, but we were listening, and it's very important to always listen and see what's going on because you can see the opportunity somewhere.
Thank you.
Thank you.
Any more questions?
Would love to have a question from one of those bright students.
Yes, thank you, Dr. Abu Alfa, for this great talk. My question is about the HCC and the new era of immunotherapy. Basically, there's a great percentage of patients who are resistant, not even resistant, but are hyper-progressing. Do you have any idea or any, like about the amount or the percentage of those patients, please?
Sure. No, that's a great question. So the question is about the idea that sometimes you give the immunotherapy, but ironically the other thing will go around in the wrong way. Rather than having tumor shrinkage, the tumor kind of like get worse. And this is what the hyperprogression is. Interestingly, remember the immune system, you are playing, a little bit playing with fire, because our immune system is well trained in all of us. It's supposed to learn when there is a certain infection, try to fight that infection. But now when you start fiddling with the immune system with the immunotherapy, by definition, you are really unleashing it. And the unleashing can go the wrong way, because while you are really unleashing it against the cancer, where you wanted to go fight the cancer, which before that it did not do so, but now you're telling it to do this. Along the way, it can go two bad problems. One of them is it can cause some serious side effects, because now the immune system is going against other organs in the body, even though it should not. That's why sometimes we hear about patients get, for example, diabetes, they can get colitis, they can get pneumonitis, and on, enough that we even can see to the extreme like Guillain-Barré and some other neurologic malignancy, neurologic illnesses. Thankfully, it's rare. But on the other hand, besides those side effects, it can cause exactly what we're hearing in the question, which is hyperprogression, which means that the tumor is now growing. Why this occurs, we don't have good clarity on the component for it. In HCC, we have seen that the alterations can really turn around the other way, because, for example, we like to have a CD8 high, CD4 low. It can really be kind of the countervert of this and really enhance it further. No clarity yet per se on this. Thankfully, it's not that common, but it could occur. And the last thing I just misspelled to say in regard to pseudoprogression is another component where sometimes the inflammation itself can really what we think it is hyperprogression, but it's simply inflammation around the tumor because of the hyperactivity of the immune system is there. So you have to really look at this not in a simplistic chemotherapy-like style, but rather in a very complex engagement with the immune system. And that's why if you're really still in second year, a good idea to focus on the immunotherapy part because it's good.
Thank you. Thank you, Dr. Boualfa.
Thank you. Thank you.
We'll now move to the second speaker.
Our second speaker is Professor Tony Choueiri. Professor Choueiri is the director of the Lang Center of Genitourinary Oncology at Dana-Farber Cancer Institute. He is co-leader of the Kidney Cancer Program at Dana-Farber Harvard Cancer Center and the Jerome and Nancy Colbert. Okay, Professor Choueiri is interested in developing novel experimental therapies and biomarkers in genitourinary malignancies, including renal cell carcinoma. He has over 850 PubMed indexed publications and is a lead investigator of multiple national and international phase 1 to 3 clinical trials in genitourinary cancer. Today, Professor Choueiri will talk about immunotherapy and cancer vaccines as applied to high-risk kidney cancer. The floor is yours.
Well, thank you very much. What an honor. You know, I didn't go to the Lebanese University, but I have many postdocs, some of them here, that went to the Lebanese University, and I congratulate you. You have nothing to fear. The world is your oyster. So let me tell you a bit about some of the work I've been doing. This talk could have gone multiple ways, but I wanted to focus on kidney cancer a bit, a disease that I have dedicated my life for. For some of you here, what about kidney cancer? These are numbers overall in the United States. It's one of the common cancer. It's a top 10 cancer with around 80,000 new cases in the US every year. And what I can tell you that 40 patients will die every day from kidney cancer. And it was a cancer when I trained, and one of the reasons, it's not that I fell in love with kidney cancer, I had someone that had kidney cancer and we had an aha moment. No, simply as a foreign medical grad in Cleveland, and luckily the word foreign medical grad is now replaced by international medical grad. At some point, by the way, it was an alien medical grad. That would have been very bad in this day and age. But, there wasn't much to do. And this was a tumor where patient with metastatic disease, still 3 out of 10 patients would present with metastatic disease, and they will go into a phase 1 directly, or into a trial where will be randomized to placebo, totally ethical. Imagine stage 4 kidney cancer. So actually nobody wanted to focus on, and it was a career suicide, but it was the only thing I had, so I went into this. And one of the things about kidney cancer, the bar is low. It's almost like pancreatic cancer now. The 5-year survival was around 5%. And I'm proud to tell you that 2 decades later, with some of the work, a lot of my colleagues, a lot of mentors, and a lot of myself, and our team has done, now the survival is 3 to 4 times more. So let me tell you where it's all started and give you a crash course a bit in kidney cancer from my perspective. This is a northern plot. This is over 20 years old. Tell you about kidney cancer. When I was an intern, and I did a year at Hôtel Dieu, so I went to the Faculté de Médecine. When I used to call for consultation, and then I moved to Cleveland Clinic, and the job of the intern, as you will see, is mostly to call for consultations. And what I can tell you, the surgeons always, when I used to tell them this is kidney cancer, they will have an aha moment, because everybody knew that this is tumor that bleed. And it was a varivascular tumor. On your left here, you can see this is a map of a blood flow to a pelvic metastasis, very red. This is in functional MRI, tell you how much this is vascularized. And this is a northern plot of multiple proteins here. And the big gorilla in the room here in kidney cancer is the level of VEGF. And Dr. Abu Alfa talked about the master protein that drive angiogenesis, that's VEGF, extremely high in kidney cancer. And that was thought to be a good target. But the whole pathway here was discovered multiple years ago, and we were part of this discovery in a way where we looked at, after the TCGA, we looked at metastatic kidney cancer, over 400, 500 patients with metastatic kidney cancer, and we did deep sequencing and looked at all the genomic available at that time. And the VHL gene is very prevalent, the mutation in VHL gene in kidney cancer. Also, VHL is mutilated, and the 3P arm, there's a 3P deletion on chromosome 3 that is a hallmark of kidney cancer, as well as many other genes deleted here, and that increases VEGF. And the biggest thing here, why kidney cancer was at the forefront of your medicine here, if you want, is the 2019 Nobel Prize in Medicine that was awarded to 3 gentlemen, including my mentor and friend Bill Kalin here, and that's taken from his Nobel talk, why this all happens. VHL as a gene that is mutated in kidney cancer is part of a machinery, a big machinery here I'm showing you on the left. And that machinery normally takes HIF, the hypoxia-inducible factor, that is a master transcription factor, and lead it to complete degradation by, in the proteasome by a process called ubiquitination here. But what happens when VHL is mutated in kidney cancer, that whole machinery doesn't work, and HIF is overexpressed. HIF is a transcription factor, and HIF leads to the overexpression of multiple downstream targets. One of them, there are many, over 200, is actually VEGF. So we were thought that VEGF is a great, molecule to target, and this is how it started. This is, before me, where bevacizumab, you're very familiar with Avastin, was used in kidney cancer in patients whose tumor progressed or were intolerant to IL-2. And while the overall survival stayed the same, 1 year in kidney cancer, we start seeing some intermediate endpoint for overall survival, like progression-free survival. People didn't hear about progression. This is one of the first, data that looked at progression-free survival, especially in kidney cancer over 20 years ago. And that is showed that bevacizumab has an effect in delaying the progression of the cancer, despite it was only 2.5 months. The 2-year overall survival stayed around 25%. So what do we do after focusing on VEGF, inhibiting VEGF? We tailor drugs that are better than bevacizumab, that are better than a monoclonal antibody, maybe more specific, maybe have a better bioavailability, etc. So we came up with the VEGF tyrosine kinases, and two examples here are pazopanib and sunitinib. I want to show you this non-inferiority trial that we were part of many years ago, where at some point the field that led to these survival benefit, look at median overall survival now, 28 months from 13, 2-year OS doubled in 10 years from 25% to 50%. But all what we were doing was just creating a better VEGF inhibitor. So a non-inferiority trial, these are VEGF receptor TKI among multiple other kinases that are inhibited. And this is compared to the pre-TKI era. But then what came is the immune checkpoint inhibitor. The time that we start having, the field being a bit boring, and I was thinking of doing other thing in kidney cancer since 10 years of, beating VEGF to death. Then the immune checkpoint inhibitor came and led to a Nobel Prize in 2018. On the left with CTLA-4, that's the paper from Jim Allison. On the right with PD-1, with Tasaku Honju from Japan. Interesting enough, my close colleague and friend and collaborator, Gordon Freeman, was the first author on the paper here in Journal Experimental Medicine. This is Gordon and I in April at the Red Sox at the Dana-Farber fundraiser. This is Fenway Park. So we were all trying to celebrate Gordon, but I think he was missed here for unknown reason. So I want to make a bold statement here, tell you about kidney cancer and what things happen where, life overall is a bit about randomness. You have to think about randomness. So I went into a specialty because simply no one wanted to do it and I had no other option. But this specialty 10, 15 years later, kidney cancer ended up being the only medical condition known to human beings at the center of 2 back-to-back Nobel Prizes that translated into therapeutic benefit. Not even polio was like that. Why is that? 2018, the immune checkpoint inhibitor with PD-1, PD-L1, CTLA-4, application in kidney cancer. 2019, the whole HIF2 VEGF axis, really one of the few indications are kidney cancer, so we combine them. So this is why I can tell you I would love to take a credit that I saw the light, but I did not. Life is randomness, and remember about that. And funny enough, my phone starts ringing now, and actually it's Nassim Taleb, the author of Fooled by Randomness, calling me probably for a meal. One of the things I want to mention that also kidney cancer was at the center of the first biomarker-based study with immune checkpoint inhibitor. I went into the IRB in 2010 and said, look, this is a trial where patient can get an immune checkpoint inhibitor, but we have to have a mandatory biopsy. And it's almost, when I said that, I committed a federal crime. Patient getting a biopsy for research? Are you out of your mind, etc.? But we were able to do it. Currently, if you go to a protocol with an investigational drug as a phase 1, and you do not require a biopsy, they all look at you and say, but how are you going to learn how the drug is doing in tissue? But this is an example. This is a baseline biopsy, and you see these cells in brown and in red, and these are the CD8 and the CD3 T cell going into the tumor after injection of nivolumab. And this is also some data about gene expression profiling using AFI. This is even before the RNA-seq, looking at CD3 and CD8 going up. So I love memes, and my kids, I have 2 teenagers, Zena and Sam, and they're all about memes. So this is how it started. This is 2003 with bevacizumab. Median overall survival 13 months, 2-year OS 25%. What do we do now? We have immune checkpoint inhibitor, right? PD-1 inhibitor. We have better TKI. We combine them. So this is nivolumab and cabozantinib. We published that a few years ago. Take a look. 10, 12 years. Median OS 50 months, 2-year OS 70%. Those are increment, where the basic science goes to the lab, back to the lab, back to the clinic, then back to the lab. We do the clinical trial, and we look at the result. And these are results that, mean something for patient. 2-year OS 25 became 70%. But the question here, yes, you're targeting one of the downstream protein VEGF. Why don't you go to the evil, to the transcription factor, HIF2 alpha? And I wanted actually to mess with Bill, my friend, and said, look, Bill, I can do that through ChatGPT. And actually, ChatGPT got it right. So VHL is the gene, HIF2 is the protein, that's the transcription factor. The transcription factor, leads to the overexpression of multiple other proteins involved in multiple oncological processes. VEGF is one of them through angiogenesis, and I did this using ChatGPT. So why not going after HIF2 here? Well, HIF2 is a transcription factor. It's hard to go after HIF2. You can't just target everything. We knew forever that RAS, another tumor that Ghassan does, pancreatic cancer, but also Aline O'Reilly, who is an unbelievably chief physician scientist and the wife of Ghassan at Memorial, pancreatic cancer. We knew forever, Ghassan, that RAS is mutated, but how could you target? It's not easy. HIF2 is a transcription factor. It's not easy. But actually, I'll tell you a story why it happened. And Bill actually got the Nobel Prize here. This is 6 a.m. picture. And I called my mom and I said, look, my good friend got the Nobel Prize. We're in the Boston Globe together. And is it a typical Lebanese mother? The Lebanese mother, she is the reason for success. Her answer was, Habibi, Mabruk, what about you? I mean, you can never win with them. And that's why we are where we are. What about you? Okay. Anyhow, so this is the basic work, buy one, get one free, 2 paper in Nature, where the HIF2 inhibitor was used, left with Jim Brugarola's lab, that was a disciple of Bill, looking at the tumors pre and post HIF2 inhibitor in mice, and right with Bill also validating the result and reinserting a mutation in HIF2 here and showing that actually this sensitivity to his HIF2 inhibitor is actually lost. We use this drug in kidney cancer, in heavily pretreated patient, median prior line of therapy 3. Most of the patient has tumor shrinkage. They drop their erythropoietin level. Why is that? Because EPO, like VEGF, is one of the downstream marker. We achieve the response rate of 25%. With a single agent, novel agent, where the response rate should be 0. We took that to a phase 3 trial, and we registered belzutifan for metastatic kidney cancer. This was paper published last year. And then you may ask me, okay, great, but look at these curves. They're okay. Yes, there's statistical value, but even the curve in orange, patient with time, they have cancer progression. So why can't you use this in a population that need the drug, in a population of HIF2 inhibitor? So what are the clinically used biomarker in metastatic kidney cancer here? And sadly, I had to do a white slide here because there is none. Despite my research, and my lab is focused on precision oncology in kidney cancer and in biomarker for kidney cancer, I'm proud to say currently we don't have any clinical biomarker in kidney cancer. Why is that? Many reasons, not because, we haven't done the work, is because kidney cancer does not really follow conventional wisdom at all. It has moderate TMB. It has the CD8 T cell infiltrate is high, but unlike other cancer, it portends a worse prognosis here. We looked at TMB with many folks here in the audience. My postdoc here, I want to welcome them, Chris Labaki and Rashad Naufal. We looked at TMB, now association with PD-1. We looked at CD8 T cell infiltration, and when I say we looked, we didn't look at 5 patients. These are phase 3 trial of PD-1 inhibitor versus non-PD-1 inhibitor, and we looked at 5 of them. Totally not. But one of the things is, when we look, we push the platform. We push the best platform we have, you know, the most evolved biomarker platform that you can think about. And we focus on usual endpoint, progression-free survival response rate. But immunotherapy is different. Immunotherapy is about exceptional responders here. And when you shift the clinical endpoint from just a regular response or a PFS to exceptional responders here, and you define exceptional responders like you define them by these patients that respond, but respond for a long period of time, have a significant shrinkage. And this is, again, work from our group. I want to recognize, in addition to Chris Labaki here, Renee Maria Salibi, who 22 years apart, she's 22 years younger than me, we had the same Arabic teacher. Believe it or not, we discovered we had the same Arabic teacher. He was my teacher at Hikmah Ashrafiyya where I went, and he moved, he upped the ranks to Nazareth, and he became her teacher there. So imagine how Lebanon is small. When you look at exceptional responder as clinical endpoint, now you start finding things that we didn't find when we correlated all these biomarkers or these genomic factors to response. When you look at clinical response, we find, for example, higher clonal neoantigen load and B cell signature, TLS signature are associated with response. And this is based on the platform that we have in kidney cancer at Dana-Farber with multiple labs where everybody that comes in has a pre-treatment biopsy and blood on therapy resistance, also a biopsy. But look at, we started with bulk whole exome sequencing, whole transcriptome sequencing. That's almost today like having a high school degree. And now we're up to spatial transcriptomic, which having almost like a PhD. Look at all these platforms that we can get. Finally, I want to talk a bit about high-risk adjuvant cancer and why I wanted to talk about adjuvant kidney cancer. That was it's still a problem in kidney cancer. These are all the studies of adjuvant kidney cancer ever. Since 1973, the first adjuvant kidney cancer study of radiation versus nothing. I was not born in 1973, and I bet many of you in the audience were not born in 1973, and some of your parents were not born in 1973. Up to 2025, 16,000 plus patients went into kidney cancer trial. Kidney cancer removed, high risk of recurrence, let's give them a vaccine, let's give them targeted treatment, let's give them XYZ, let's give them radiation. No overall survival benefit till we hit overall survival benefit when one of the study was pembrolizumab. So this is dear to my heart. Finally, we're able to say there is a drug in high-risk patient that predicts survival here. But one of the problem I have, even if you look at the curve in green, right? Even if you look at it, one of the things is patients still experience recurrence. So what can we do? Is there a way where we can get better? After all, even though the patient are at high risk of recurrence, surgery alone, our surgeons are good. They cure a large, potential of patient. So how can we do better? First of all, we have to select patient better. So some of the tumors should not be treated. So chromophobe kidney cancer, it's a rare form of kidney cancer, and I asked all the time, it wasn't part of this trial where we included it. So we interrogated the chromophobe kidney cancer very much so, and Chris Labaki and Ziyad Bakaouni and other, Chris here is in the audience, say hello and embarrass him please, led this study, and yesterday night, After dropping me at the hotel, he went to the university and stayed till midnight to finish the proofs and send them to JCO. So we're proud that this was accepted in the Journal of Clinical Oncology, where we showed that chromophobe renal cell cancer, looking at single cell sequencing, among other things, has low infiltration of immune cell, has non-expanded T cell repertoire, and the immune phenotype is non-exhausted. So this would be, you know, almost a contraindication to an immune checkpoint inhibitor. So this is one semi-personalized approach. Another personalized approach I'm proud to, that took 9 years, is the vaccine. We published this in Nature, where I was the senior author with Kathy Wu and David Braun here. And what is a personalized cancer vaccine? And this is really making strides in oncology now. It's not easy. It's not for every patient. It's not easy to make. It needs a large team, and it doesn't work every time. But typically, you have the tumor, you remove it, and you sequence the DNA, and you see among these mutations that the tumor has, which one has the highest chance to elicit an immune response. This is as simplifying it as I can, okay, because it's not as simple. And this is one of the things that I personally struggled with. So once you look at all those mutations, we go into a tumor board. It's called Tumor Neoepitope Tumor Board, where you look at the literature, you look at several models, you look at some published model artificial intelligence to predict the HLA interaction to see which mutation are the most immunogenic. I can tell you this tumor board, neoantigen tumor epitope boards were at 8 a.m. Once a week, and by 8:10 I would need double the amount of coffee to survive them. And by 8:30 I would just be crashing. So we still survived, and then what you do once you know the mutation, you manufacture the vaccine and you give it back to the patient. I don't want to go into details, but I love this. Rather than going through the publication, there's a website, acir.org, that made a very funny cartoon out of it. We took 9 patients. After 3 years, none of the patients recurred. All the patients were able to synthesize the vaccine, and the cells from the patient were reactive to the tumor cells, and most important, they were reactive against the neoepitope. So I will spare you the details, but that's another personalized way to steer the immune response towards you. There is around 275 steps in making the vaccine, from first seeing the patient to injecting the patient with the vaccine. But at least this led to a randomized phase 2. It took us 8 years to have 9 patients and millions of dollars from donors, from grant, etc. But of course here, Merck and Moderna had to join forces. Both huge, had to join forces for 272 patient study that I'm co-leading here with V940, the vaccine and immune checkpoint inhibitor. And finally, the most personalized way ever in any adjuvant therapy is this that I'm going to show you, that one of my postdocs did it. Let's say you have a cancer and you remove, let's say kidney cancer. Hopefully at some point, the technology going to be so advanced that you can detect really cancer in the blood. I'm going to keep it as simple and as superficial. But it is what it is. And how do you detect cancer in the blood with ctDNA, etc.? It's not one size, fits all. And I'll show you why it's very hard in kidney cancer. But hopefully, if this is detectable after surgery, of course, in prostate cancer, another tumor we have the luxury of the PSA. In the vast majority of tumor, we don't have that luxury. If you have a detectable ctDNA, hopefully you'll give intense therapy. And if you don't, you de-intensify therapy. The problem in kidney cancer is this. This is 21,807 tumors that are all metastatic or stage 3. And we look at currently available technologies for ctDNA. This is Garden test, a liquid biopsy. You see here renal, it's so low. This is almost like brain cancer. It's almost, undetectable. The sensitivity is one of the ctDNA fraction is one of the lowest. The only lower is brain cancer for good reason, the blood-brain barrier. But we're working with many. This is the work of my lab with Matt Friedman, and we have an initiative about that. We're looking at methylation pattern of the genome, and think about ChIP-seq if you're familiar with the science in blood that could detect the tumor, kidney cancer especially, at low level. And of course, we're using the urine here, and Rashad Naufal became really an expert in urine methylated DIP-seq and ChIP-seq, which he's probably the only one in the world to know it like that. So this is my summary, and thanks for bearing with me. This is kidney cancer that was celebrated in back-to-back, pre-COVID, back-to-back Nobel Prizes. I am an optimist. You have to be an optimist. We have to be an optimist in Lebanon. Why? Because we don't have another choice. As simple as that. But look at this. A trial when I started my career in 2000 would yield a metastatic kidney cancer survival of 15 months. We're up to 47 months. And look at this. After 52 years of attempt and shots on goal, we have an adjuvant treatment in kidney cancer. I would love to say this is my work, but this is not my work. This is a huge team here, starting with my lab, but the multiple other labs that we work on, and we converge here on one malignancy, and I cited them here, including my R01 funding in the lab, my Department of Defense funding, and all the funding, including some of the philanthropy I receive and the patient. But I think my proudest moment is the list of the MDs and the PhDs I mentored, and I continue mentor here. I have two in the audience. One is currently, was Chris Labaki, 3 years with me. He's a postdoc with me 3 years, and Chris is a resident in the Harvard system, internal medicine, and Rashad Naufal, finishing and applying. He's with the Friedman lab and my lab. I have accepted someone here, and we're interviewing. So this is when you come to Lebanon, you do 10 things at the same time, interviewing someone else here. And I wouldn't forget my family. You asked me about balance. Maybe I have no balance, I'm proud to say. This is my family at work, behind the Fenway Park, the home of the Red Sox, Boston Red Sox, and this is my family here, my wife Sue, my daughter Zena, who just turned 16, and my son Sam, who just turned 14. Thank you for your attention.
Dr. Choueiri, for this very interesting presentation. We are a little bit late, so we have room for maybe a maximum of 2 questions.
Yes, please.
Fascinating, and it's cause for optimism, as you say. I just have a question about the vaccination part of your talk. So you remove the tumor, you identify antigens, match them to HLA, etc., and you go into this, what you call grueling process. There is a school out there that says that perhaps one way to give this a kickstart would be to, for example, go intratumorally and kill cancer cells and have the cancer cells release the tumor antigens. And then you can perhaps kickstart the immune system, the immune response to that. Is there first, do you think that's credible for many patients? And second, can these two be combined?
Yeah, outstanding. Of course, we have a therapy in melanoma approved like this because these are superficial tumors. The problem with this approach is simply that most of the tumors are not accessible, beside melanoma and other, but we have an approved treatment. We are approving them. Our focus is neoantigen for vaccine because of Cathy Wu and other we work on, but we have other focuses. I mentioned maybe this is 10% or less of my actual research. Another area that we're expanding to is natural killer cell, where we infuse natural killer cell in kidney, bladder cancer, GU malignancy. We do CAR-NK, and we in the lab have multiple grants and effort to make the best CAR-NK that secrete protein that fight the tumor microenvironment. One of the biggest issue in CAR-T, CAR-NK, we're doing CAR dendritic cell, is the horrible tumor microenvironment that is so immunosuppressive in solid tumors.
Thank you.
Thank you very much for your presentation. We're coming to Lebanon. We are happy to listen you today for the progress in kidney cancer. I want to ask you just why the kidney cancer is no more aggressive than another type of cancer, because kidney cancer is not aggressive. How you can explain that if we want to compare to another type of cancer?
So kidney cancer can fool you. There are multiple behavior of kidney cancer, from the indolent type, where you should not even touch it, to types that are very, very, very aggressive. Very aggressive. And the median survival is less than 3 months sometimes. Sadly, I deal with a lot of these. So it could be very aggressive. We have multiple underlying genomic factor, BAP1, etc., certain tumor profile that make it, very aggressive. And hopefully now we have adjuvant treatment for it. It could be very aggressive. It doesn't follow wisdom.
I'll take the privilege of a third question, a very fast question. The neoantigens that you are finding and the peptides you are making for the vaccines, do you find a really very big difference from one patient to another?
Yeah.
In the sequences? It's very diverse?
Absolutely. It is very diverse and it's very different. Not each mutation is the same, but most patients end up making mutation against the cancer driver, like VHL, PBRM1, BAP1, SETD2, those are cancer driver, and they do make such. But there was an attempt actually many years ago to do it against VHL only. We didn't have the same advances as in sequencing, and I still believe multiple shot on goals are way better. It's going to be very, very hard to cure cancer with one modality. Maybe we put it in some remission. But I'm a big believer in combination. I wasn't like that. I was trained that in the era of CML. I was trained BCR, ABL, etc. I think that fooled us more than helped us. We cured cancer with combination. We cured HIV with combination. We cured TB with combination. It makes sense to use combination. It's going to be very expensive, maybe not tolerable, financially, not the greatest thing, but metastatic cancer is probably going to be cured with combinations, at least solid tumor, till we find prevention and early screening. It is happening, hopefully my lifetime.
Thank you. Thank you very much, Dr. Chouairi.
So thank you, Tony, again, and thank you for supporting all medical students across Lebanon. So we are going to move to another talks with Dr. Muhammad Haidar. Professor Muhammad Haidar graduated with MD from the Lebanese University. His studies became oriented towards nuclear medicine. He did his nuclear medicine training at Université Paris 7 in France, and he completed his academic in several fellowship training positions. He's also European board certified in nuclear medicine, and he's member of the Royal College of Physicians. Prof. Haidar is full professor at the American University of Beirut since September 2024. He's the head of Division of Nuclear Medicine. He's also founder and director of the Nuclear Medicine Fellowship Program. which is an advanced fellowship program in the region. He's the chairperson on the Radiation and Laser Safety Committee at AUB MC. He's also Assistant VP for Business, Faculty of Medicine at AUB. He's the president of the Lebanese Nuclear Medicine Society and the Arab Society of Nuclear Medicine. He's also Vice President, Asia Oceania Federation of Nuclear Medicine and Biology. He was also senior advisor to the Minister of Public Health. Dr. Muhammad Haidar is currently the Minister of Labor. Dr. Haidar, the floor is yours.
Thank you, Hazen, for this presentation. First of all, it's my pleasure to give a lecture at the Lebanese University because it is my university when I did my MD in medicine before going to France for the specialty. Thank you, Dr. Bedran, and thank you, Dr. Saad and Dr. Hachiti for the invitation. So, I will try to talk about the new technology and the new era of diagnostic and treatment of prostate cancer. I will talk about, I have nothing to disclosure, as you know. Okay. As you know, prostate cancer is the first cause of cancer in males with almost 27% of all cases, and he is the second cause of death in male, almost 11% of cases, of all cases. We know the overall survivor for 5 years of prostate cancer, depending of the staging. When we have local disease or regional disease, the overall survival for 5 years is almost 100%, and which is decreased significantly when we go for stage 4 with metastatic disease. When we talk about metastatic disease, distant metastasis, we know the first site of metastasis is bone metastasis. Almost 90% of men who die of prostate cancer have bone metastasis. This is the life road of a patient with prostate cancer. Start with diagnosis and with the death. During this life, we have staging, restaging, biochemical relapse, we have treatment by hormone therapy, by chemotherapy, and now by radionuclide therapy. And in every stage, and every period, nuclear medicine can have a role in diagnosis and in restaging of the disease to help for the management. I don't know. So the new molecule used now in nuclear medicine is PSMA. PSMA is prostate-specific membrane antigen, but in reality is not specific for prostate cancer. When we found this molecule in almost 2012, we started to tell it's specific for prostate cancer, it's a specific radiotracer we can use, but with time and with experience and with research, we found that PSMA exists in many types of cancer with different percentage and intensity. So it's a protein, cell surface protein, which is a glutamate carboxypeptidase 2. He exists in normal cells also and increased in prostate cancer cells. So we have physiological uptake, we have uptake in lacrimal gland, salivary gland, parotid, liver, spleen, kidney, and bowel, and of course bladder. And the intensity depend of the intensity of the number of the receptors. So normally for prostate cancer, we use MRI to diagnose lesion within the prostate gland, and normally it was a history, and we still do MRI for to localize a lesion or to study a suspicious lesion before biopsy, because now we go for target biopsy for prostate lesion to have accurate result. But there is a role of the PET scan, and when we talk about role of PET scan, PET PSMA, I don't talk about replacing MRI. It's complementary, and the result from PET and MRI can be very helpful, especially when we have suspicious lesion with virus 3 or virus 2 and with high level of PSA. This study, primary study, it was a comparison between PET and MRI to see if MRI superior or PET superior in to detect prostate lesion and to characterize the lesion. So in this study, 296 men were included. We did MRI first, then biopsy, and after that PSA, and we compared the result, PSMA, and we compared the result. And we found that the negative predictive value of, you can see that? No. Okay. Okay. So now you can see it. Negative predictive value is 83% sensitivity for MRI versus 90 for PSMA, and when we compare both, we can see the sensitivity of both technique increase the sensitivity and increase the negative predictive value. So the complementary information from MRI and PET is very helpful for localization and also to select the lesion, a highly suspicious lesion for biopsy. And we found that when we have a high uptake of PSMA, that means we have aggressive disease. So SUV max, which our indicator used in PET scan to measure the intensity, is very helpful to select for low grade from high grade prostate cancer. And by the end, they found that if we take any pirates from 2 to 5, and we compare the result from MRI and PET, we found that the result with PET is superior, especially when the SUV max is superior of 12 and any type of pirates of prostate cancer. So another study showed that also the combination is better. When we took the information from MRI alone, our sensitivity is almost 60%, but if we versus PET scan 65%. If we combine both, we can increase our sensitivity to 76%. And why PET is more important? Because we have the indicator is SUV max, and we can see we can easily select a high suspicious lesion versus a low suspicious lesion related to high uptake. In our institution, we did this study to see for the Lebanese people and also patients from the Arab region to see if this technique can be helpful. But we used in this study to segmentation of PET as the segmentation of MRI. Normally in PET we use segmentation of 6 segments versus 36 segments in the MRI. So in this study, we select the same segmentation and to see if we can increase our sensitivity. Normally, the sensitivity of PET to detect the malignant lesion within the prostate gland is almost 67% worldwide, related to the size of the disease and the intensity of the uptake. So, and we found that our sensitivity is almost 68%, but the specificity is higher. Normally, the specificity is around 90% if we take only 6 segments, but if we take much more segment, our specificity increased. And why? Because we can detect better smaller lesion. I give you an example why PET can be more helpful to detect disease. This is an example of patient with the lesion within prostate gland. You can see the lesion here. PSA level was 7.5. Glycemic score after biopsy was 8 at the right lobe, and this is the lesion. It's highly suspicious in the MRI, and this is the image of the PET scan. It's very active lesion, but which is very important. We detect this tiny uptake. It's tiny uptake corresponding to tiny millimetric lymph node, suspicious for metastasis, and turn it out to be micrometastasis focus of 2 millimeter. Why it is very important? Because this lesion is in the mesorectal region, and normally with the rectal region, we don't do lymph node dissection. We do normally lymph node dissection for the external and internal iliac, and sometimes for common iliac. And why it is very important? Because that means after surgery, the patient need adjuvant treatment by radiotherapy. Normally, we used for staging for many years bone scan for certification of prostate cancer and to select a patient for surgery. When we have normal bone scan, normally we tell the physician we don't have distant metastasis. We can go for radical prostatectomy, and even if you have a lymph node, we go for extended lymph node dissection of the pelvic lymph node. So many studies after that compared the result of bone scan with PET scan. They found that the PET scan is superior to bone scan to detect micrometastasis and distant metastasis. Why? Because first, the sensitivity of the machine is better. When we compare gamma camera versus PET scan, sensitivity is almost a few millimeters for the PET scan versus 1 centimeter for the scintigraphy. Second, the background to tumor ratio with PET scan is superior to tumor to background is superior to bone scan, and we can detect easily the lesion within the bone. So now the recommendation and the guideline, if you have a PET scan, you don't need to do bone scan. You go directly for PET PSMA to select distant metastasis. I show you an example. Why it's very important. This is an example case of prostate cancer, Gleason 8, T3, PSA 73. Normally, it's localized disease with the MRI within the prostatic gland, no extension to the seminal vesicle, bone scan completely normal, negative. So with this result, the decision normally should be radical prostatectomy. Now, with PET PSMA, we found that we have metastatic lymph node. We can see it here in pre-rectal region. But which is very important, we found first small lesion within the superior thoracic spine and another lesion in the lumbar spine with no significant abnormality on CT scan in keeping with bone metastasis. So we have bone metastasis, microbone metastasis detected only by PET, and we have change in management from radical prostatectomy to systemic therapy plus minus local radiotherapy for the prostatic gland. So now it's confirmed in the guidelines. If you have availability for PET PSMA, you go for staging with PET PSMA. What about restaging? This is international study published in JNM, Journal of Nuclear Medicine, American Journal of Nuclear Medicine. It was prospective trial led by IAEA. UPMC was one of the participants in this study. We collect more than 1,000 patients from 15 countries, and we compared our result with MRI, bone scan, and standard of care for follow-up. And we found that our new technique can change the management, and we have impact in clinical management in most cases, more than 57% of cases. So now for restaging also, in this prospective study, we confirmed that, and many studies followed this study showed the same result for restaging. PET PSMA has accuracy. This is an example, many examples about that. First example, PET scan is completely negative. In this case, completely negative for recurrent disease, but we have biochemical recurrence. In this case, we go for radiotherapy to the pelvis. In the second case, we have metastatic lymph node detected by small, tiny lymph node. You can see it on CT scan. Is almost a few millimeter. Very hard on CT scan to tell they are metastatic disease. So the treatment now modified from localized radiotherapy to the pelvis to hormonotherapy. In the third example, we have metastatic disease to the bone. We can see a lesion here, a tiny lesion in the spine, and now we go for a systemic treatment by hormonotherapy. So to change management, PET is an essential technique, and it's a game changer. Also, in our institution, we did prospective study to see in our population, and we can found the same result. We found the same result, but which was very important, and we found that doubling time of PSA level is very important. Why? We found that we have increase in our sensitivity to detect distant metastasis when doubling time is inferior to 10 months. Our sensitivity was 71% versus 29% for doubling time. It's superior to 10 months. So also it's very important, can give us the behavior of the disease, give us an idea about our sensitivity and the role of our technique. So PSMA till now is the best radiotracer, but it is not perfect. So one size cannot fit all. Why? Because if we take a look for multiple studies, so that the sensitivity increased with PSA level to detect metastatic disease or recurrent disease, but it's not 100%. We still have some percentage we cannot detect the recurrent disease. So, for example, when PSA level is superior to nanogram per milliliter after radical treatment, so our sensitivity is superior to 90%, not 100%. Why? Because metastatic disease started with millimetric lesions, cannot be detectable by the technique, or has not have a high affinity for our molecule, our vector PSMA. So we found many studies found that when the lymph node is very small, the sensitivity can be very low, from 50% to 90%. And for example, it's 50% when the lymph node is almost 2 millimeter, and increased to 90% when the lymph node is superior to 4 millimeter. So our technique is very good, but it's not enough. We still have false negative, and we need to work on it, and we work on it, and you have many new tracers now used in the research to show us if we can detect millimetric lesions. And now with the new technique of PET-CT, because we shifted our technology from analogic technology to digital technology, and our sensitivity was normal for detection normally is 5 millimeter with analogic technology, and now we go for 1 to 2 millimeter with digital technology. So hopefully in the near future, the result will be better. Now we know PET-PSMA is a game changer for the management of prostate cancer, can change from active surveillance to systemic therapy, or vice versa, from systemic therapy to local therapy. Now, PET-PSMA is a standard, used as standard when it's available to stage and restage of prostate cancer. Second part, what about theranostic? Theranostic, that means we use same molecule for diagnostic and therapeutic. We know we use PSMA for diagnostic when it's labeled with gallium. Ligand is the vector, is PSMA, and the target is the prostate cancer. So now with a new technique, we can use the same molecule for diagnostic when we use radioactive material for diagnostic such as gallium, and we go for therapeutic if it's labeled with therapeutic molecule, lutetium or actinium or terbium or any other molecule for treatment. What is the difference? For diagnostic, we use only molecule emit gamma rays or positron rays, but by the end we have gamma rays, and for therapeutic we have beta rays and alpha rays. So this is the difference. First image here is PET scan. It's diagnostic. We can see the lesions. We have high uptake within the bone metastasis. And another image is the image of gamma camera used to image lutetium PSMA with beta rays and a small amount of gamma rays because that we have this image. And you can see the resolution of the image between PET and the gamma camera. Of course, the image of PET is better. Why? Because the resolution of the machine is better. In theranostic, now we can see the lesion here. We can see the lesion, and we can treat with lutetium, and we can see the uptake. So we can see what we treat. This is the difference between radionuclide therapy and chemotherapy and hormonotherapy. Chemotherapy and hormonotherapy is systemic, but we cannot see exactly what we target. Here we can see exactly which kind of treatment of tumor is treated or targeted by our treatment. And also we can select patient before to tell if our treatment will be efficient or not. If we have low uptake, that means our result will be, we have low chance to have complete remission. If we have intense uptake, that means our treatment is efficient and we have higher chance to get remission. So we can select patient before between responder versus non-responder or less responder. So as I mentioned, we have two rays for treatment, alpha and beta, and small summary, we started to use theranostic for prostate cancer in 2012, but we get FDA approval in 2022. In Lebanon, we started our study to do it in 2016. We started first patient treated by lutetium PSMA, and 2015 we used the PSMA gallium for diagnosis. So what about the result? So it's radioactive material, radionuclide therapy, and it's efficient when we compare to the standard of care, I mean hormonotherapy or chemotherapy, first line and second line. So many study, prospective study show that. One of the famous one is the VISION study. It was the first international prospective, open-label, multicentric, randomized phase 3 study. Normally, this study, we do that routinely in oncology when we study any molecule, any type of cancer, and when we, for response versus non-response for chemotherapy or for immunotherapy. But in nuclear medicine, it was the first study randomized and phase 3. We compared the role of lutetium versus protocol permitted standard of care versus only standard of care. And we showed that with lutetium, we have decrease of PSA level more than 50%, almost in 46% of cases versus 7% of cases of standard of care used for treatment of metastatic of prostate cancer. And if we have decrease in 80%, more than 80% of PSA level is very important because give us an idea about the response to treatment or not, if our treatment is efficient or not. So if we take the part of more than 80% is almost 33% versus 2% for the normal treatment. But which is very important also, we compared the image-based progressive-free survival, and we found that we have big difference between lutetium and standard of care, almost 9 months versus 3.5 months. So for first idea, we have a difference, but which is very important, is the overall survival. We found we have 15 months of overall survival versus 11 months with good quality of life. Good quality of life, decrease in pain, but which is very important, patient treated by lutetium showed that time to first symptom skeletal event, it was decreased when we compare that to standard of care. So with and overall survival was, time to first symptomatic skeletal event was 11 months, 0.5 for lutetium versus 7 months for standard of care. So this study followed by another study is the therapy study, compared the treatment by radionuclide therapy to chemotherapy, first-line chemotherapy and second-line therapy. And we compared radionuclide therapy to patient treated by Taxol-based treatment, and we compared the result. And we found that we have PSA reduction more important with lutetium, 66% versus 37% in comparison to chemotherapy. Progressive-free survival was almost 50%, 19% versus 3%, and objective response rate was 50% versus 24%. But which is very important, the adverse events. It was lesser with lutetium, radionuclide therapy, and alpha therapy versus chemotherapy. But it was an indication in the selection. Why? They took only patient with positive PSMA, this is a PSMA, and positive FDG in the same lesions or negative FDG. When we have negative FDG and positive PSMA, that means our treatment can be helpful. And when we have only positive FDG and negative PSMA, or less uptake with PSMA, that means our treatment will have a chance to fail to treat this patient. So they exclude this type of patient, PSMA negative FDG positive or PSMA positive FDG positive but discordant, and only took when it's positive PSMA negative FDG and positive PSMA and positive FDG but concordant. As they found that lutetium is better than cabazitaxel for progressive-free survival, but for overall survival is almost similar. In sub-analysis, we took the non-selected patient and we compared that. We found that the overall survival, okay, it's similar when we took part PET positive, PET PSMA positive and FDG negative, but if we select the other type of patient, the overall survival is better when we compare to the patient with no uptake of PSMA. So when we compare these two studies, we can find that we have better progressive-free survival, better reduction of PSMA, and better overall survival when we compare to standard of care and chemotherapy. Because that now PSMA lutetium is in the guidelines and can be used as second line treatment after first line based Taxol chemotherapy. And in some new studies, they started to use it after hormonal therapy. When we have failure to treatment, they give the chance to patient between chemotherapy and radionuclide therapy. I will take 2 minutes more to show you our experience in this type of treatment. As I mentioned, we started in 2016. This treatment is started worldwide in 2015, and we was a pioneer to bring that in the Middle East in 2016. In May 2016, first patient treated by this type of treatment. We started with lutetium, then shifted to actinium, and we found that I will go for the result. We had a complete remission in 12% of patients, progressive disease in 26% of patients, and other patients had stable disease. Our adverse effect events was very low and mainly was hematological toxicity. I will show you some examples. One patient, first patient, 82 years old male, history of prostate cancer with lymph node and bone metastasis, treated by hormone therapy and chemotherapy, but PSA is still increasing, and the quality of life, it was acceptable. COG was 1, and PSA level was 210 after many type of treatment. This is the baseline PET. We can see we have diffuse bone metastasis. This patient treated by 3 cycle of lutetium. After that, we still have decreased in activity, but still had diffuse metastasis. We shifted to actinium, and after 2 cycles of actinium, we can see we have significant response to treatment, and the PSA level decreased from 210 to 2.5 with good quality of life and less pain. Another example about the role of radionuclide therapy. Another patient, 81-year-old man, treated by ENZA, then by multiple type of chemotherapy. PSA response and pain improved during treatment, but came up quickly, and we had a raising of PSA and the recurrence of bone pain. So we decide to treat this patient by lutetium. After 3 cycles of lutetium, we can see we have significant decrease in bone metastasis and lymph node metastasis. We have here multiple lymph node metastasis, small lymph nodes. But during follow-up, this patient developed right ear melanoma, not related to treatment, and treated by surgery. And this patient last seen in our clinic in January 2003 with PSA level at 0.41. So, as I mentioned, we had adverse event, mainly hematological, but we have very good response to treatment, especially quality of life and decrease in bone pain. My take-home message, PSMA is a game changer now, can be used. It's used now for staging and restaging of prostate cancer, and PSMA with MRI information add improved sensitivity to the assessment of local tumor extension compared to multiparametric MRI alone. It's superior diagnostic. Improves the assessment of disease, notably within pelvic lymph nodes, to select patient operable versus non-operable. Improve survival rates compared to conventional approach, and alpha and beta treatment can be considered for prostate cancer when we have failure to chemotherapy, and we can shift it to alpha treatment when we have failure of beta emitter treatment. Thank you very much.
Thank you, Dr. Haidar. We are 30 minutes behind, so we have room for one question. So it seems very complicated topic, Muhammad.
Yeah, I know.
So I have a question. The cost, like, is this because I have been asked by the moderator about accessibility?
Yeah.
Is that accessible to the Lebanese patient?
Yes. When we started in 2016, it was very hard to get patient because it was from their pocket money. Now, PSMA is covered by the insurance, by Social Security, and even by the MOPH. For diagnostic, of course, and for treatment, it's covered by insurance, and some cases covered by MOPH, but demand Social Security till now not cover treatment by lutetium.
هيدي شغلتك تظبطها.
Yeah, شغلتي. We'll do it. We started to do it. I discussed that with Dr. Karaki, and we start to see how we can include that in the treatment, because it's FDA approval, and now it's approved after first-line chemotherapy, so we need to include that for metastatic prostate cancer. But when we compare the price of the lutetium to second-line chemotherapy, okay, the price is almost half of price of chemotherapy. So even if it's not covered, but still accessible for the patient.
Thank you, Muhammad. ويعطيك ألف عافية. I know how hard you work those days. محمد بيشتغل 18 hours now. He has to.
Thank you.
So we are going to move on. So I'm happy, as I'm the only male on the podium, I'm going to present Dr. Awada. I'm a minority here. No, I'm a minority. So Dr. Awada is going to talk about the evolution of therapy and concept in solid tumors, more patient benefit and personalized approach. Professor Ahmed Awada is the head of the oncology department and director of the Chirac Cancer Institute in Brussels, Belgium. He previously served for 7 years as the head of the Department of Medicine at the prestigious Institut Jules Bordet, where he led numerous innovative initiatives in cancer care research. With a distinguished career spanning decades, Prof. Awada has developed extensive clinical expertise in the management of solid tumors, particularly breast cancer, has played a pivotal role in the development of new anti-cancer therapy, including cytotoxic agents, molecular target therapy, and immunotherapy. Prof. Awada is an active member of the several leading international scientific societies, including ASCO and ESMO. He also holds the position of Professor of Clinical Medicine and Medical Oncology at Université Libre de Bruxelles, where he actively involved in teaching and mentoring the next generation of oncologists, including many Lebanese oncologists working in Lebanon right now. Prof. Awada is the author of 32 book chapters and published over 400 articles in peer-reviewed international journals. Thank you.
Thanks, Hazim, for the nice introduction. Thanks to Professor Badran and Hachiti for inviting me to. I am part of this meeting since the beginning, and really I am honored by that. I was also honored to have the title of Doctor Honoris Causa from this university when I was a student in 1979. So that's really my great honor here. So my task in 20 minutes, I try to give the main message from my presentation because we are out of time. So we are speaking about the personalized medicine. Clearly, we are in this way, but there are a lot of, let's say, achievement, but also a lot of challenges and difficulties. And I will try to give you where we are now in the management of solid tumor. Let's say my disclosure. You know, before to speak about molecular oncology, personalized oncology, it's important to remember that patient characteristics are really the basis of patient characteristics. The age of the patient, status, tumor status of the patient, the characteristic of the patient, the socioeconomic status of the patient, even the microbiome is important on the efficacy of drugs, for example, immunotherapy. So before to go to molecular therapy, important to remember the patient characteristics. It's important also to remember the partner of molecular oncology. Of course, biologists play a major role in defining the target, and even passenger now signaling play a role because we are using this as target for ADCs, antibody drug conjugate. From other side, the pathologist, the clinical researcher, of course, and chemists. And chemists always are forgot in this, let's say, scheme. I think the chemists play a major role in building new drugs as well, new antibodies. So, before to go to the therapy, it's important to remember that pathology has moved from histology, immunohistochemistry. Now we have more and more molecular biology. We have next generation sequencing. We are using this in clinical practice. And for some tumor time, genome profiling. So someone could ask the question, why to do next generation sequencing today in our patient with solid tumors in order to generate genomic aberration, which could be used as, let's say, prognostic, predictive, target for therapy. We can understand by doing NGS the evolution of the disease at the molecular level because we know the evolution is dynamic. Third, we can guide therapy if we have very nice target important in the carcinogenesis process. We can target it by a new therapy. And finally, genome profiling is really important to escalate therapy as we are using this in breast cancer. Let's move now to therapy. Of course, therapy of cancer is evolving. We have surgery. I think the surgery we have robotic used more and more now. Radiotherapy changed a lot the last 15 years, more precise. Let's say we can give less doses on the normal cells and consequently less toxicities. Chemotherapy is still used, and we will continue to use chemotherapy, but now we have a new kind of chemotherapy called ADCs, targeted chemotherapy to some extent. We have molecular target therapy, we have immunotherapy approach, and we heard from Professor Haidar the value of radionuclide therapies, and I can tell you this is really more to come in this field. Let's very quickly to give some important messages from all this development. ADCs is really important new part of therapies in solid tumor. ADCs, what's mean ADCs? We have cytotoxic agent linked chemically to monoclonal antibody, which drive the chemotherapy agent to the specific cancer cell. To some extent, really, we can call it targeted therapy. The first one I used was in breast cancer, TDM1, but now I can tell you ADCs are available in many solid tumors. Breast cancer, bladder cancer, endometrial cancer, cervical cancer, and I am sure that we have more an ovarian cancer and more to come. Let's move now from ADCs to targeted therapy. What is the basis of targeted therapy? The basis of molecular targeted therapy is the understanding of the biology of cancers, and you are aware of the hallmark of cancer, proliferation, angiogenesis, and so on. But we have now an updated version of this with epigenetics. I think epigenetics play a major role in the carcinogenesis process, but unfortunately, epigenetics is something very difficult to target because it's very complicated. Metabolism play a role as well, senescence. Let's give some important message. Professor Shweri really mentioned a lot about angiogenesis and the role of kidney cancer. I think by using anti-angiogenic drug, tyrosine kinase inhibitor, anti-VEGF, VEGF trap, we observe clearly benefit in terms of responses, median progression-free survival, and to some extent survival. But we achieve a plateau, for example, with anti-angiogenic drug. But now there are renewed interest, as we heard from Professor Shweri, by combining anti-angiogenic agent with immuno-oncology, we have very good results in renal cell carcinoma, but also in endometrial cancer. Molecular target therapy, I have the chance to participate to many phase 1 involving targeted therapy are summarized in these 3 slides. I will not go in details. You can see in these 3 slides, in each slide, the target is on the left, the tumor type, the inhibitors, the molecular target therapy developed, the predictive marker sensitivity or resistance, and the disease setting. The main messages from these 3 tables, we have a lot of new drugs, molecular target therapy, which improve the benefit, improve the outcome of our patient. That one message works well in metastatic disease, but not all in the adjuvant setting where we cured patient. That's important message too. And the third, we do not have for all this targeted therapy the biomarker predictor of sensitivity or resistance. And this is really a big weakness in spite of huge, let's say, effort done in the biomarker field. But anyway, this field changed completely the therapy of our patient. As you can see, and I can update this table at each meeting we have, because in each meeting we have 2-3 new molecular targeted therapy. Dr. Shady speak about renal cancer. I will give another example, breast cancer. And breast cancer, even if we have one important, let's say, marker target in breast cancer, let's take the example of HER2 amplified tumor. 10% of our patients with breast cancer, HER2 could be targeted at the extracellular domain as well as the intracellular domain. And even at the extracellular domain, we can target this by a different epitope, like with trastuzumab from one side, pertuzumab from the other side, but we can target this also at the intracellular domain with the development of tyrosine kinase inhibitor. And I can tell you we are really curing a lot of patients today, not in the metastatic setting, but in the adjuvant setting by using this new kind of therapy in HER2 amplified breast cancer. Immunotherapy is a really important part now in our armamentarium. We understand basically, at least partially, why the tumor is tolerated by the immune system. One of the reasons is PD-1, PD-L1 expression. I will not enter into details because we have had good example in renal cell carcinoma, but it is important to know there are many antagonists, checkpoint inhibitors in development, but so far we have only CTLA4 inhibitor, PD-1, PD-L1 inhibitor, and LAG3 inhibitor. If we take the other side of the immune system and we gave agonists to stimulate the immune system, so far no major breakthrough. So it's really important to understand why a lot of development. I did, for example, the phase 1 of OX40 drug, a huge number of patients entered this clinical trials, unfortunately was negative. So from sometimes we have success, but sometimes we have failure in our development. Immunotherapy really interesting because help a lot of patients with solid tumor. As you can see here, we have immunotherapy is established activity in many solid tumors, and there the question today, how we can use this immunotherapy in the adjuvant setting in order to cure some patient. And there we achieve some benefit and sought improvement of outcome, but in other situation, unfortunately, was a failure. We have also some moderate activity in other tumor type like ER positive or more receptor positive breast cancer. And the question here, how to improve the tumor activity. Some of the investigators, and we are involved in that, we are using in the neoadjuvant setting to put in addition to immunotherapy and chemotherapy, radiation. Some doses of radiation in order to transform, let's say, this moderate activity to immunotherapy in better activity. And there are still, important to remember, a lot of tumor type where immunotherapy is not working, at least PD-1, PD-L1 inhibitor, and the question here, how to transform this cold tumor in a hot tumor. And the only mean probably is to combine, to use bispecific molecular antibody, which target immune function as well the tumor type. So other immunotherapy approaches are in the development, CAR-T, probably in selected patients, but still in development, but already standard of therapy in selective hematological malignancies, intratumoral injection of oncolytic viruses, no major breakthrough. Bispecific antibody is emerging, and we'll have a lot of bispecific antibody, probably we're already in clinical research and will be used in clinical practice, and we heard some example about vaccine. There are a lot of challenges, heterogeneity of tumor, resistance to therapies. This is a perpetual problem, not only with chemotherapy, with molecular target therapy, with immunotherapy, with ADCs, still a major problem. Some target could be difficulty to target, like PC53, important in the carcinogenesis of many solid cancer, RAS signaling. There are new side effects, ocular toxicity, lung toxicity with all these new drugs, in particular the antibody drug conjugate. The brain met emerge as a problem as well. All this influence the organization as well the methodology of clinical research. So to give you an example, I think it's important to remain positive. Even RAS signaling pathway, which is present in many solid tumor, is difficult to target. But now we started to target this one, at least for one mutation, KRAS G12C, where we have at least 2 new agents, at least 2, and now we are developing pan-KRAS inhibitors. So the major mean to reverse the resistance, of course, the combination therapy, as Professor Shwedi mentioned in his talk. There are other also challenges in developing all this new therapy. You know, technology is evolving fast and will be difficult, and it's difficult for us to follow this development of technology. Hopefully, to some extent, artificial intelligence will help in some direction there. I think one of the major challenges is the availability of the drug for our patient. There are a lot of challenges in clinical research, methodology, and organization. There are ethical and legal challenges, and also there are problems by doing several invasive biopsy for our patient, but I am sure that liquid biopsy is really something really important, not only for clinical research, but also for clinical practice. And tomorrow, I think Dr. Hampi Khoury will speak about liquid biopsy and the value of liquid biopsy from the screening of cancer to the end of life. Liquid biopsy could help us to document the presence of the tumor at low level, to document the tumor response monitoring, to understand the resistance of mechanism, to define the minimal residual disease after curative therapy. So there are a lot of advantage by using liquid biopsy in our clinical research as well clinical practice. Hereditary cancer is really an important topic. You know, 10 years ago is around 5 to 6% of our cancer are from hereditary cancer, but now by doing NGS to our tumor, we are finding more and more hereditary cancer, and we can say the percentage of hereditary cancer today is around 12 to 15%, and this percentage will probably increase with time. We are not improving only the therapies by developing ADCs, molecular target therapy, immunotherapy approach, theranostic, and so on, but also we are evolving in the concept and strategy and the therapeutic approach. Only to mention this new concept in the management of solid cancer, we are escalating therapy in some patients, we are de-escalating on some patients. Example, in hormone receptor positive breast cancer, by using gene profiling of our tumor in hormone receptor positive, we are de-escalating the chemotherapy, we are denying the chemotherapy in 50% of our patients. And that is really a major achievement, less costly for the society and less toxicity and for our patient. The concept of oligometastatic disease, but here I think it's important to separate what's called oligoprogressive disease, in my opinion, could help the patient but not cure the patient, from what's called oligosensitive disease, where we should put a lot of effort there to cure some of our patients. Brain met is a major challenge, and of course, new concept with this molecular segmentation of solid cancer lead to the concept of organ agnostic therapy. What's mean organ agnostic therapy? That means we do not mind with the origin of the tumor, but only with the gene abnormality, which is a target for cancer therapy. Example, BRAF mutation could be targeted in melanoma, non-small cell lung cancer, thyroid glioma, TNRK in many solid tumors, in adult patients as well in pediatric patients, and PARP inhibitor, for example, in breast, ovarian, pancreas, prostate. We have PARP inhibitor in all these tumor types, provided that the tumor and the patient had a BRCA mutated tumor. So with all this development, fortunately, in spite that the incidence is increasing, the mortality is decreasing. And so I propose to go to the general conclusion. So we can say today that patient and tumor characteristics are important for personalized oncology, not only molecular oncology. Patient characteristics are really important. Innovation in science and technology shape the present, the future of clinical research methodology, organization, and clinical cancer care. And our network, OncoDistinct Network, is really cope with this evolution. Integration of molecular biology, molecular targeted therapies, immunotherapy, and targeted chemotherapy, antibody-drug conjugate in clinical research and clinical care is a reality in practice. And finally, the most important comment is this one, that all these developments are fine and remain invention if they did not reach the patient. We cannot speak about innovation, exception, if the patient receives these new things, we can say at this time our innovation. If not, we'll continue to speak about invention. And with that, I would like to thank you for your attention.
Thank you. Thank you, Dr. Awada. We have room for a few questions.
I have a question, Dr. Awada. So we know genomic sequencing is not available in all countries, and even in Lebanon, we have a big resistance to genome sequencing. How are you going to how are we going to face these challenges in molecular precision medicine? Do you have any recommendation or?
I think, yeah, for the moment probably it's a little bit difficult because it seems to be a costly approach. But I can tell you technology is evolving. I think with time will be more and more cheaper. That's one thing. Second, I don't think that we should do next generation sequencing to all patients. I think we should do it when we expect, if we found really an abnormality, and this abnormality is present, let's say, in more than 10% of the cases. So in this situation, and if we have the drug to offer our patient, in these cases, I will advise to do NGS. Because it's important not to do NGS to say to the patient, I had in your tumor very, very nice mutation, but I do not have the drug for this mutation. I think that's important to be clear with the patient.
Okay, thank you. So maybe we ended up by the morning session, and we'll have the opening ceremony by 12, I believe. Thank you.
Thank you. شكرا دكتورة عليمي. شكرا للحضور الكريم. هلا في عنا بريك، بنرجع على القاعة على الساعة 11:30 تحضيرا للأوبننج سيريموني. يعطيكم العافية.